For extrauterine survival, a newborn has to replace the fluids in his lungs by air. This can be achieved by two methods. The first involves the squeezing of the fetal chest wall by the birth canal and takes place during the birth of the baby. This looks after 1/3 of the fluid of the lungs. For the rest of the 2/3 of the fluid, absorption into the perialveolar lymphatics and blood vessels takes place. This happens when the baby takes the first few breaths.
Majority of the newborn babies, when they are born, they do not require any modes of resuscitations. They either cry immediately after birth, right during the head is taken out, or if the baby is, once the cord is cut, or the baby is immediately after the delivery from the passage of the canal, the baby cries. But there are certain situations where one will have to assist him take breath. Now this may require in about 3 to 5% of cases. The interventions required may be just very small, or it may not be really interventions or putting into some instrumentation into the baby. Just giving a stroke on the sole or pad on the back may initiate the breathing, or even putting the suction catheter and taking the mucus from the air passages will initiate breathing. So they are very few in number, but sometimes one is confronted with the very difficult task of initiating the breathing in the newborn baby.
For doing a perfect resuscitation, you will have to equipped with proper equipments. You should have an environment which is definitely conducive to the baby. Therefore, you should have a radiant warmer under which the baby has to be placed. Now, in situation where you don't have a radiant warmer, you can place a 200 watt just Phillips bulb placed about 1.5 feet above the baby. The essential simple equipment needed for resuscitation is a suction apparatus, which is also known as Dilly strap. Now in this particular Dilly strap, which is a disposable one-time use, you just do suctioning with this end and with your own mouth, and with this end you do suctioning in the baby. You can use a suction bulb, and while you are using this suction bulb, you will have to first squeeze the bulb, and then you will have to do suctioning, and suctioning of the mouth first, followed by suctioning of the nose. You can do a simple innovation at your own center. If you do not have Dilly strap or a suction bulb, you can cut just an IV set, and the Murphy's chamber of the drip set will act as a suction apparatus, and with this end you just suck from your mouth, and this end will act as a suction catheter. Apart from that, you may have an electric suction apparatus, but please remember that whenever you use an electric suction apparatus, the negative suction pressure should never exceed minus 100 millimeter of mercury, because it is usually the practice that the same suction apparatus is being used for both mother as well as the baby. Another thing you must remember is that for suction of a newborn baby, you will have to use a big bore catheter of the size of about 8 to 10 French size catheter, and not the feeding catheter which is used as a French 5 size catheter, because the mucus which is there in the baby's mouth is very thick and viscid, and you will have to use a large bore catheter for that. The other equipment which you should always have, is an embo bag. It is a self-inflating bag, and this is the embo bag. The other bag which is there, this is another self-inflating bag which is being used nowadays. This is Lardial bag. I will first demonstrate to you the parts of this particular bag. This portion which you can see from here is known as the oxygen inlet, in which you will have to connect the oxygen, and the flow of the oxygen should be around 5 to 7 liters per minute. So you connect it with the oxygen source. This is the air inlet through which air enters. This is the proper bag, and this particular bag is made up of rubber material and which can be sterilized only by either 2% glutaraldehyde or by spirit, that is alcohol. This portion is known as the valve assembly. You can just see this is the valve assembly, and this valve assembly is attached to this bag proper. In this valve assembly there is an inspiratory valve which is there. There is an expiratory valve which you can open and see the inspiratory valve here. You can see the inspiratory valve. You can put it back again, and you can just see the expiratory valve here. You can fit it again. This valve should not be jammed, and it should be cleaned time to time so that this resuscitation can be done properly. This portion which you can see here, this is the patient outlet, and with the patient outlet you attach the ventilatory, that is the mask. The masks are of different shapes. This is a round shaped mask which you can see here. The other type of mask which you can see here, this is an anatomical shaped face mask, and this anatomical shaped face mask should be placed in such a way that you can put the pointed portion towards the nose. The size of the mask should be such that it covers the chin, the mouth and the nostrils, and it does not cover the eyes. This is very important. The other part of this bag which is very important, and this is a corrugated tube, and which should be attached to the oxygen inlet, that is to the air inlet, not oxygen, with the air inlet, and this is known as the oxygen reservoir. You will have to attach it like this. Now what happens, if you want to give almost near 100% oxygen, you will have to definitely use this oxygen reservoir. Once you squeeze the bag and you release it, oxygen which is attached to the oxygen inlet goes in, and along with that the air is also going in. So it's a mixture of oxygen and air, and about the resultant output will be around 60% oxygen which is going. Now if you want to increase the concentration of oxygen, you attach this oxygen reservoir. What is going to happen? Oxygen, after collecting inside the bag, the excess of oxygen gets collected into this corrugated tube. The pressure of the oxygen being higher than the pressure of the atmospheric air pressure, the air which is there inside this particular tube, which will get displaced, and therefore you will find this whole corrugated tube will be filled up with oxygen and not air, so that when you squeeze the bag and release it, it is the oxygen which is entering, and also the oxygen which has been collected into this particular corrugated tube is also entering, the resultant output being near 100% oxygen. And that is what is the present day recommendation, although in future you may hear that it is only the air which is required and not the oxygen, but till that time we should be using oxygen reservoir. So these are the equipments which are absolutely essential. I am not going to talk to you regarding the laryngoscope and endotracheal tube, which is very rarely required in the resuscitation of a newborn.
That's a very important thing, I think, which Dr. Datta has just now mentioned, that simple things like using just a 100-watt bulb, using a mere tube for suction, and an ambu bag which you can easily carry in your doctor's bag. So all these things are very readily available even in a village setup. So if you have to resuscitate newborns who are born at home or in a village, in a sub-center, in a PHC, it can be easily done. We don't require very sophisticated equipments for resuscitating a newborn. My only apprehension, there are two apprehensions, Dr. Datta. First is you mentioned that we have to use oxygen. Now, oxygen may not be available in a village kind of a setup, or if delivery takes place at home, since most of the deliveries in our country take place at home. So, can we use this ambu bag without oxygen?
Yes, Ruchika, you can definitely use. You should not be too much bothered about whether oxygen is there or not, and it is not practically feasible to have oxygen even in many primary health centers, and even in many district health centers it is not possible. Even in certain medical colleges also, sometimes the oxygen supply is not there. So you should not be unnecessarily puzzled for not having oxygen. Basically what you need is the expansion of the lungs, which you can do even with air. And nowadays there are several studies which have been conducted, and even Dr. Siddharth Ramji is with us. His very important study on room air is already has shown a promising result in this aspect, and maybe another few years we will be using only air and not oxygen in the resuscitation. So don't get perturbed if you do not have oxygen. And I just forgot to tell about this particular bag. This is also another silicone bag which is nowadays more available, and this is the original L'Oreal bag, and it has also got the same thing, oxygen inlet, air inlet. This is the oxygen reservoir, and this is the bag proper, and this is the safety valve. This safety valve in this particular bag is there, which is hidden because there are two layers are there, and the excess air or excess oxygen and air combination, this gets entry into this particular, in between these two layers, if there is excess of air, as you can see here. And here, if it is an excess pressure, if you are giving, the air gets out through this valve, which is known as safety valve. And this is the valve assembly. There is an inspiratory valve, there is an expiratory valve, and this is the face mask which is attached. This bag is very useful because you can, this is a silicone bag and which can be sterilized by autoclaving, and this bag you cannot autoclave.
As I mentioned, Dr. Datta, that as you rightly mentioned, that oxygen may not be required in most of the places. Since it's not available, it's not even, it doesn't matter even if it's not available. But we have another kind of doctors in another kind of setup where all the facilities are available. Now, my apprehension is there were a lot of studies that 100% oxygen to babies can also cause a lot of harm. What do you want to say about that?
I do not like to say anything right now about this 100% oxygen controversy for this particular group of people, because there are still all those are in the research tool, I will say, and the free oxygen, free radical or reactive oxygen species, its injury, and what are the remedial aspects of that. These are still in the research field, and I would not like to further elaborate and would not like to confuse this group of students on this particular issue.
So you would like to suggest that they should continue using the bags without worrying much on the 100%
Yes.
oxygen issue at
If
present.
it is available, please do use. If it is not available, don't get perturbed and use only the bag and mask without any oxygen, and you will do a good justice, and you will resuscitate and revive most of the babies without any disability later on.
One last question, Dr. Datta. You showed us two masks, one as the anatomical mask and the other a round mask. Now, if a doctor has to purchase his resuscitation equipment, which mask would you suggest and why?
Any mask is good enough, but I prefer somehow this round mask which has got a cushioned rim, and this cushioned rim helps in giving a tight fixing with the mouth as well as mouth, and that's why it is preferable than the other mask, which does not have a cushioned rim. So the chances of injury can be more with this, the chances of injury will be much less with a cushioned rim. This is more useful.
I would now request Dr. Ramji to tell us that when is it that a baby requires resuscitation, because we know that all babies, like Dr. Salan mentioned, majority of the babies do not require any resuscitative help, but there are about 3 to 5% babies who may require, and it is very essential to give them the required resuscitative help so that we can prevent and reduce the mortality in the newborn. So could you just mention, Dr. Ramji, and also could you outline the various steps which are involved in resuscitation?
Yeah. I think the first thing is how do you recognize that we have a baby in front of us who needs resuscitation? I think the answer to this is relatively simple. Our whole objective is that a baby soon after birth must begin to use his own lungs. I think that's very fundamentally important. Intrauterine, this baby as a fetus was receiving all the oxygenation through the placental circulation. Once this connection has been severed, it is mandatory for this extrauterine existence, the baby must begin to breathe. So obviously any baby who is not breathing effectively, and when I mean effectively means there is no good cry or there is no good regular expansion of the chest taking place, we say that this baby is not breathing well. Or obviously you may have a baby who is just not breathing at all. So if you have a baby who is not breathing at all, or a baby who is just gasping, that's the recognition of a baby at the time of delivery that this baby requires resuscitative assistance. Now the question is that what kind of resuscitative assistance do we really have to provide to these babies? Well, there are some babies, I think you can recollect what Dr. Sullivan said right at the beginning, that not all babies require the same level of intervention. Well, the simplest intervention, of course, is to simply carry out an oropharyngeal suction. You have a baby in front of you, and Dr. Datta showed you a mucus sucker. So all that you need to do is to carry out a suction of the oropharynx. Quite a few babies would probably have the airway cleared and start breathing quite effectively. There are babies, of course, who may not breathe adequately even in spite of airway clearance, and they may need some kind of stimuli, some kind of a tactile stimuli. So what we can provide is some kind of tactile stimuli to this baby. Now, well, I'll tell you what you should not be doing, and what traditional people have been doing. It's not uncommon for you to see a baby being hung like this and being whacked thoroughly blue and black, and you still find the baby doesn't breathe. We really don't need that kind of handling. We need much gentler and much briefer amounts of intervention. So what we really need to do is to kind of stimulate the soul of the baby. A couple of firm flicks on the soul 3 or 4 times, or gently rub the back like this, and that's enough. If a couple of times does not initiate breathing, then we obviously know that this is a baby who requires something beyond. And that something beyond could be either just assisted ventilation with a bag and mask. It could mean giving chest compression if the cardiac perfusion is not enough. Or it could also mean that we may have to use several variety of medications like adrenaline, soda bicarb, or fluids, whatever it be. But the 3 basic things that we have to always keep in mind when we initiate a resuscitative process is, number 1, the breathing of the baby. That's very important. Constantly check the adequacy of breathing. Number 2, we have to ensure the circulation is adequate, which means looking at the heart rate of the baby. And number 3, a combination of adequate ventilation and adequate perfusion should result in a pink baby, which means you look at the color.
And I would request Dr. Datta to elaborate the steps involved in the initial steps which will be involved in resuscitation.
Initial steps are very important, and almost 90% of the babies, they would be requiring and they will get benefit from the initial steps of resuscitation. I would like to demonstrate to you how the initial steps of resuscitation are to be carried out. For initial steps, at the very beginning you will have to make an arrangement for a table where you will have to bring the baby and keep the baby. And beforehand you will have to keep a radiant warmer or a bulb, 200 watts Philips bulb, above the baby, and this is maintaining the temperature. We will learn our alphabet in English with A, B, C, but here in resuscitation, you please remember you learn your alphabets with T, A, B, C. Here T stands for temperature regulation, A for airway maintenance, B for initiation or maintenance of breathing, and C for maintenance of circulation. And that is what is very, very important. Another important message which I would like to give to all of you is that time is very, very vital in resuscitation. You should not unnecessarily waste in doing a single procedure without further evaluation. And that is why when you take an action, after an action you will have to first take another evaluation after 30 seconds of that action, and after that evaluation you take further decision and then take further action. It may be the same action which you may be taking, but you will have to evaluate, make a decision and take further action. And that is what is the action, evaluation, decision, action cycle which you must remember. Now in the initial steps, as you bring the patient, you will have to put the baby, first step is that put the baby under a radiant warmer. And after that, immediately what you do is that you dry the baby. Now while drying the baby, please remember that you will have to dry the front, you will have to dry the head and face, and you will have to dry the back portion of the baby, which is very important. While putting the baby in the initial steps, most important thing is putting the baby in the proper position. Now for putting the baby in proper position, slight extension of the neck has to be done. So first a sheet or a towel has to be folded, which should be about 1 inch thick, and this towel has to be placed under the shoulder like this. So this is known as a shoulder roll, and which has to be put under the baby, and this will act as the baby for keeping the baby in slight extended neck position. This is the position which should be maintained all throughout the procedure of resuscitation, whether it is initial step, whether it is bag and mask ventilation, whether it is chest compression, or whether it is even medication or intubation. The next step which you will have to do is doing a suctioning, for which you can take any one of the suction apparatus which I have already told. If you take this bulb suction, you will have to first squeeze this bulb like this, and after squeezing the bulb, you will have to put it inside the mouth. So you have done suction of the mouth, and then you do suctioning of the nose. So first suctioning of the mouth, followed by suctioning of the nose, and this is the way you will have to do suctioning. If you are using a electric suction apparatus, as I have already told you, you should not use a very high suction, negative suction pressure. After you have done suctioning, you will have to simultaneously observe whether the baby is breathing or not. If the baby is not breathing, then what Siddharth Ramji has told, you will have to do tactile stimulation, and for this, as he has already mentioned, you give 2 strokes on the sole or 2 sharp slaps or rubbing on the back. Any one of this procedure has to be done. Please remember that you are not to put the baby's head upside down, neither you will have to slap the baby like this. These are all which will not help any way in this baby. Sometimes it will be dangerous, because if you put the baby's head upside down, and you may increase the cerebral edema and increase chance of intracranial hemorrhage. The next step which you will have to do, when you have found that the baby is breathing, and if the baby is breathing normally, then you will have to look for the heart rate. Now heart rate you will have to observe only for 6 seconds heart rate, count only for 6 seconds. This is the only situation where 6 seconds heart rate is counted, and if the 6 seconds heart rate is 10 or more, that means 1 minute's heart rate is more than 100, and we are very, very happy. If the heart rate is less than 10 in 6 seconds, we are definitely worried, and this requires further resuscitation. Suppose the breathing is normal, the heart rate is also normal, then you will have to look for the color of the baby. If you find that the color of the baby is pink, or if there is a small peripheral cyanosis which is normal, because peripheral cyanosis remain there in almost 60% of the babies, so we are not much bothered. But if the baby is cyanosed, there is central cyanosis, this is a baby where it requires free flow of oxygen. Previously, many of us used to give oxygen much earlier. Now this is the step where you should give free flow of oxygen. Now I will demonstrate to you how free flow of oxygen is given. You will have to have an oxygen source, and the catheter may be placed just half an inch away from, like this, you can keep half an inch away from the nostril. This is the way you can keep it, and you are giving around 80% concentration of oxygen. If you find that the baby is pink, now you increase the distance from half an inch to 1 inch now. You are giving around 60% concentration of oxygen. If you find the baby is pink now, you increase the distance now 2 inches from the nostril, and you are giving around 40% concentration of oxygen. If you find that the baby is pink now, then only you remove the oxygen, and do not remove the oxygen catheter abruptly. You can use oxygen with the help of an oxygen mask also, and first the mask has to be put just closed or tight to the mask, held tightly over the face, and you are giving around 60 to 80% concentration of oxygen. If you keep the mask loosely, you are giving 40 to 60% concentration of oxygen, and if with this the baby is pink, now you can remove the mask. This is the way free flow of oxygen is being given. I would come to another situation which is very, very important. Sometimes you are confronted with a case where there is a thick meconium staining of the Leica amnii. In such a situation, if you are confronted, at just when the baby's head is out, you will have to do suctioning of the mouth, and that is very, very essential. You ask your obstetrician to just do a thorough suctioning of the mouth, and then only the baby has to be taken out. I would not like to tell you much details about later on the endotracheal intubation and other things, but at least this is a simple procedure which you can do. You will prevent in most of the cases meconium aspiration syndrome.